involve shock. Again, I've spread the slides over 2 sections because they were too long. So 50 slides-ish each, and here we go. So 50 slides-ish each, and here we go. Shock is a syndrome characterized by decreased tissue perfusion and impaired cellular metabolism. There's an imbalance in the supply and demand for oxygen and nutrients. The exchange of oxygen and nutrients at the cellular level is essential to life. When the cell experiences a state of hypoperfusion, the demand for oxygen and nutrients exceeds the supply at the microcirculatory level. These are the classifications of shock: cardiogenic, hypovolemic, distributive, and obstructive. You can look at Table 67.1 for more information. Although the cause, the initial presentation, and the management strategies vary for each type of shock, the physiologic responses of the cells to the hypoperfusion are similar. Cardiogenic shock is about low blood flow. There is systolic or diastolic dysfunction and compromised cardiac output. The mortality rate for patients with cardiogenic shock is upwards of 60%. Decreased filling of the heart will result in decreased stroke volume. Systolic dysfunction is the heart's inability to pump the blood forward. Primarily, this affects the left ventricle because systolic pressure is greater on the left side of the heart. When systolic dysfunction affects the right side of the heart, blood flow through the pulmonary circulation is reduced. Causes of diastolic dysfunction are listed in Table 67.1. The precipitating causes of cardiogenic shock include myocardial infarction, cardiomyopathy, blunt cardiac injury, severe systemic or pulmonary hypertension, cardiac tamponade, and myocardial depression from metabolic problems. Here's a graphic depicting the pathophysiology of cardiogenic shock. Whether the initiating event is myocardial dysfunction, a structural problem like valvular disorder or ventricular septal rupture, or dysrhythmias, the physiologic responses are similar. The patient experiences impaired tissue perfusion and cellular metabolism because of cardiogenic shock. The early manifestations of cardiogenic shock include tachycardia, hypotension, a narrowed pulse pressure, and increased myocardial oxygen consumption. The early clinical presentation of a patient with cardiogenic shock is similar to that of a patient with acute decompensated heart failure. The heart's inability to pump blood forward will result in a low cardiac output, less than 4 liters a minute, and cardiac index, less than 2.5 liters per minute per meter squared. Your physical assessment will show tachypnea and pulmonary congestion, pallor and cool, clammy skin, decreased capillary refill time, agitation, confusion, and anxiety. There's an increase in the pulmonary arterial wedge pressure and a decrease in the renal perfusion and urine output. In hypovolemic shock, there are 2 types. Absolute hypovolemia, which is a loss of the intravascular fluid volume caused by hemorrhage, GI loss, like vomiting and diarrhea, fistula, drainage, diabetes insipidus, hyperglycemia, and diuresis. Or a relative hypovolemia, which results when fluid volume moves out of the vascular space into extravascular space, and this is termed third spacing. One example of a relative volume loss is leakage of fluid from the vascular space to the interstitial space from increased capillary permeability, as seen in burns. This is a depiction of the pathophysiology of hypovolemic shock. In our case study, AM is a 26-year-old man who arrives via paramedics to the emergency department with multiple gunshot wounds to the abdomen. He's unresponsive, his blood pressure is 58/30, his heart rate's 146. What type of shock is he experiencing? It's likely that he's experiencing hypovolemic shock, right? The gunshot wounds caused hemorrhage. Okay, so what other clinical manifestations would you anticipate besides hypotension and tachycardia and unresponsiveness? The patient's response to an acute volume loss depends on the extent of the injury, the age, and the general state of health. The overall assessment of physiologic reserves may indicate the patient's ability to compensate. A patient can compensate for a loss of up to 15% of the total blood volume, which is approximately 750 milliliters. Further loss, up to 30%, will result in sympathetic nervous system mediated response. This response results in an increase in the heart rate, an increase in the cardiac output and respiratory rate and depth. Stroke volume and central venous pressure, or CVP, and pulmonary artery wedge pressure, or PAWP, are decreased because of the decreased circulating blood volume. The clinical manifestations of hypovolemic shock include anxiety, tachypnea, increase in cardiac output and heart rate, and decrease in stroke volume, wedge pressure, and urinary output. If the loss is greater than 30%, the volume must be replaced. Loss of autoregulation in the microcirculation and irreversible tissue destruction occur with loss of more than 40% of the total blood volume. Common laboratory studies and assessments that are done include serial measurements of hemoglobin and hematocrit levels, electrolytes, lactate, blood gases, central venous oxygenation, or SCVO2, and hourly urinary outputs. The third type of shock is distributive shock, and one type of distributive shock is neurogenic shock. This is a hemodynamic phenomenon that can occur within 30 minutes of a spinal cord injury at the 5th thoracic vertebra or above, T5 or above, and it can last for up to 6 weeks. The injury results in massive vasodilation without compensation due to the loss of the SNS vasoconstrictor tone. This massive vasodilation leads to a pooling of blood in the blood vessels, tissue hypoperfusion, and ultimately impaired cellular metabolism. See Figure 67.4. Depression of the vasomotor center of the medulla from drugs such as opioids or benzodiazepines can also lead to decreased vasoconstrictor tone of the peripheral blood vessels, resulting in neurogenic shock. This is a depiction of the pathophysiology of neurogenic shock. The clinical manifestations of neurogenic shock include hypotension and bradycardia, temperature dysregulation, which results in heat loss, dry skin, and poikilothermia, which means the patient takes on the temperature of the environment. Initially, the patient's skin will be warm owing to the massive dilation. As the heat disperses, the patient is at risk for hypothermia. Later, the patient's skin may be cool or warm depending on the ambient temperature. Tables 67.2, 3, and 4 further describe the clinical presentation of a patient with neurogenic shock. Another kind of distributive shock is anaphylactic shock. Anaphylactic shock is an acute, life-threatening hypersensitivity or allergic reaction with massive vasodilation, release of vasoactive mediators, and increased capillary permeability. Anaphylactic shock is a hypersensitivity reaction to a sensitizing substance, whether a drug, chemical, vaccine, food, or insect venom. As capillary permeability increases, fluid leaks from the vascular space into the interstitial space. Anaphylactic shock can lead to respiratory distress due to laryngeal edema or severe bronchospasm and circulatory failure from massive vasodilation. A patient can develop a severe allergic reaction, possibly leading to anaphylactic shock after contact, inhalation, ingestion, or injection with an antigen or allergen to which the person has previously been sensitized. The clinical manifestations of anaphylactic shock include anxiety, confusion, and dizziness, the sense of impending doom, chest pain, and incontinence. The patient experiences a very sudden onset of symptoms. Again, a patient can have a severe allergic reaction, possibly leading to anaphylactic shock, after contact, inhalation, ingestion, or injection with an antigen or allergen to which the individual has previously been sensitized. Parenteral administration of the antigen or allergen is the route most likely to cause anaphylaxis. However, oral, topical, and inhalation routes can also cause anaphylactic reactions. The third kind of distributive shock is septic shock. Sepsis is a systemic inflammatory response to documented or suspected infection. So severe sepsis equals sepsis and organ dysfunction. In as many as 10 to 30% of patients with sepsis, the causative organism is not identified. Severe sepsis is diagnosed in more than 750,000 patients every year, with mortality rates as high as 28 to 50%. Septic shock includes the presence of sepsis with hypotension despite fluid resuscitation. There is the presence of inadequate tissue perfusion resulting in hypoxia. The main organisms that cause sepsis are gram-negative and gram-positive bacteria. Parasites, fungi, and viruses can also cause the development of sepsis and septic shock. Here's a depiction of the pathophysiology of septic shock. Septic shock has three major pathophysiologic effects: vasodilation, maldistribution of blood flow, and myocardial depression. The clinical manifestations of septic shock include increased coagulation and inflammation, decreased fibrinolysis, with the formation of microthrombi and obstruction of the microvasculature, and a hyperdynamic state with increased cardiac output and decreased systemic vascular resistance. When a microorganism enters the body, the normal immune inflammatory responses are started. However, in severe sepsis and septic shock, the body's response to the microorganism is exaggerated. Endotoxins from the microorganism's cell wall stimulate the release of cytokines, including tissue necrosis factor, interleukin-2, and other pro-inflammatory mediators that act through secondary mediators such as platelet activating factor and interleukin-6 and 8. The release of platelet activating factor results in the formation of microthrombi and obstruction of the microvasculature. The three major physiologic effects are vasodilation, maldistribution of blood flow, and myocardial depression, evidenced by decreased ejection fraction and ventricular dilation. Patients may be normovolemic, but because of acute vasodilation, relative hypovolemia and hypotension occur. The ejection fraction typically improves and the ventricular dilatation resolves over 7 to 10 days. Persistence of a high cardiac output and low systemic vascular resistance beyond 24 hours is an ominous sign and is often associated with an increased development of hypotension and MODS. Other clinical manifestations include tachypnea and hyperventilation, temperature dysregulation, decreased urine output, altered neurologic status, GI dysfunction, and respiratory failure. The patient will initially hyperventilate as a compensatory mechanism, resulting in respiratory alkalosis. Once the patient can no longer compensate, respiratory acidosis will develop. Respiratory failure will develop in 85% of patients with sepsis, and 40% will develop acute respiratory distress syndrome, or ARDS. These patients will need to be intubated and mechanically ventilated. Tables 67.2 and 4 describe the clinical presentation of a patient with septic shock. Obstructive shock develops when a physical obstruction to the blood flow occurs with decreased cardiac output. This can be from restriction to diastolic filling of the right ventricle due to compression or abdominal compartment syndrome. Pulmonary embolism and right ventricular thrombi cause an outflow obstruction as blood leaves the right ventricle through the pulmonary artery. This leads to decreased blood flow to the lungs as well as decreased return to the left atrium. So the patient will experience decreased cardiac output, increased afterload, variable left ventricular filling pressure. Rapid assessment and immediate treatment are very important. Other clinical signs include jugular vein distension and pulsus paradoxus. Back to our case study. AM's heart rate continues to increase and is now 188 with a BP of 50/32. He has had no urine output since admission. Bowel sounds are hypoactive and his skin is cool and clammy. What stage of shock is AM experiencing? What compensatory mechanisms are working to maintain cardiac output? Well, the stage of shock is compensatory, and the compensatory mechanisms we'll cover on the next slides. The initial stage of shock is usually not clinically apparent. The metabolism changes from aerobic to anaerobic, so lactic acid accumulates and must be removed by the blood and broken down by the liver. The process requires unavailable oxygen. In the compensatory stage of shock, changes are becoming clinically apparent. Neural changes, hormonal changes, and biochemical compensatory mechanisms are working. There are attempts being made by the body to overcome the consequences of anaerobic metabolism and maintaining homeostasis. The patient's clinical presentation begins to reflect the body's responses to the imbalance in oxygen supply and demand. This is a depiction of the compensatory stage of shock. Baroreceptors in the carotid and aortic bodies activate the sympathetic nervous system in response to decreased blood pressure. There is vasoconstriction while blood to the vital organs is maintained. Decreased blood to the kidneys activates the renin-angiotensin system, which increases venous return to the heart. One of the classic signs of shock is a drop in blood pressure, which occurs because of a decrease in cardiac output and a narrowing of the pulse pressure. Blood flow to the most essential or vital organs, the heart and brain, is maintained, while blood flow to the non-vital organs such as the kidneys, GI tract, skin, and lungs is diverted or shunted. The decrease in blood flow to the GI tract results in impaired motility and a slowing of peristalsis. This increases the risk for the development of a paralytic ileus. Decreased blood flow to the skin it results in the patient feeling cool and clammy. The exception is the patient in early septic shock who may feel warm and flushed due to a hyperdynamic state. Shunting blood from the lungs increases the physiologic dead space. The physiologic dead space is the anatomic dead space, or the amount of air that will not reach gas-exchanging units, and any inspired air that cannot participate in the gas exchange. This results in decreased arterial oxygen levels, an increase in the rate and depth of respirations, and a VQ mismatch. There will be areas of the lungs participating in ventilation that will not be perfused because of the decreased blood flow to the lungs. Arterial oxygen levels will decrease, and the patient will have a compensatory increase in the rate and depths of respirations. The sympathetic nervous system stimulation increases the myocardial oxygen demands. If the perfusion deficit is corrected, the patient recovers with no adverse sequelae. If the deficit is not corrected, the patient enters the progressive stage of shock. The progressive stage of shock begins when compensatory mechanisms fail. Aggressive interventions to prevent multiple organ dysfunction syndrome must be taken. Changes in the patient's mental status are important findings in this stage. This is a depiction of the pathophysiology of the progressive stage of shock. The hallmarks of the progressive stage of shock are decreased cellular perfusion and altered capillary permeability. There's leakage of protein into the interstitial space and an increased systemic interstitial edema. The cardiovascular system is profoundly affected in the progressive stage of shock. Cardiac output begins to fall, resulting in the decrease in blood pressure and coronary artery, cerebral, and peripheral perfusion. Anasarca is the diffuse profound edema caused by fluid leakages that affect the solid organs and the peripheral tissues. There's a decrease in blood flow to the pulmonary capillaries. Another key response in the lungs is the movement of fluid from the pulmonary vasculature into the interstitial space. As capillary permeability increases, the movement of fluid to the interstitial spaces results in interstitial edema, bronchoconstriction, and a decrease in functional residual capacity. With further increases in capillary permeability, the fluid moves to the alveoli, with resultant alveolar edema and a decrease in surfactant production. During the compensatory stage, blood flow to the lungs is already reduced. In response to the decreased blood flow and the SNS stimulation, the pulmonary arterioles constrict, resulting in increased pulmonary artery pressure. As the pressure within the pulmonary vasculature increases, blood flow to the pulmonary arteries decreases, and ventilation perfusion mismatch worsens. The cardiac output begins to fall, causing decreased peripheral perfusion, hypotension, weak peripheral pulses, and ischemia of the distal extremities. Myocardial dysfunction results in dysrhythmias, ischemia, myocardial infarction, and the end result is complete deterioration of the cardiovascular system. The GI system is also affected by prolonged decreased tissue perfusion. The effect on the kidneys of prolonged hypoperfusion is renal tubular ischemia. The patient will have a decreased urine output and an elevated blood urea nitrogen, or BUN, and serum creatinine. Metabolic acidosis occurs from the kidney's inability to excrete acids, especially lactic acid, and reabsorb bicarbonate. The loss of the functional ability of the liver leads to the failure of the liver to metabolize drugs and waste products like lactate and ammonia. Jaundice results from the accumulation of bilirubin. As the liver cells die, enzymes become elevated. For example, alanine aminotransferase, aspartate aminotransferase, and gamma glutamyl transferase. The liver also loses its ability to function as an immune organ. Bacteria that may move from the GI tract are no longer destroyed by the Kupffer cells. Instead, they are released into the bloodstream, thus increasing the possibility of bacteremia.